Today, as we introduced, I mean, we're going to talk a little bit about bisphosphonates and the medications. They have a wonderful use. Definitely, these are important medicines. So, I mean, when we talk about bisphosphonates, I mean, in the dental community, you hear that word, and it's a buzzword like, oh my gosh, this is a horrible thing. Why are we using these drugs? I mean, when you get vertebral fractures, when you get hip fractures, those are horrible. They're really very, very bad things happen with those. So there's important reasons we use those medicines. But you do have to be careful when some of these medicines are there, especially for longer periods of time, because you can get some of that bone necrosis, especially in the mandible. It happens in the maxilla or the mandible. You can definitely get it. And in some of those cases, very few, thank goodness, but they can be very devastating as far as managing those from our side of the house. So, you know, I'm not going to give you anything crazy as far as anything brand new, but there are things that we're trying to do to capture these things a little bit earlier to prevent that from going a little bit further and being more devastating. So we'll talk a little bit about that. So we're going to talk about risk assessment, prevention strategies, and patient management in here today. So when you look at some of the indications for the bisphosphonate medications that we use, there are some main ones, and osteoporosis is the biggest one as far as, especially for the oral medicines. So I mean, there's several several different indications, though, oftentimes for Paget's disease. You don't see that very often, but Paget's disease, and we'll talk a little bit about that. You can get metastasis from cancers, especially cancers that affect the bone, and what that does is that puts a whole bunch of calcium, so people get hypercalcemia, which goes into the bloodstream, and they bones, you know, there's sayings for that to memorize kind of what, you know, what that causes, but that can be very devastating. So oftentimes the IV medicines that we'll use are going to be very important as well. So Iridia and Zometa are ones that we see a lot as far as the patients with the bisphosphonate-induced necrosis. So the IV ones are a little bit worse, certainly worse than the oral ones as far as causing these problems. But there's several different reasons why we'll use the medications, which Dr. Kohlmeyer is going to go over as well. The first bisphosphonate really to be introduced was in the 1980s was Didronel, and that was for Paget's disease. Iridia was the first IV bisphosphonate that we added in there, so that was introduced in the 1990s, and that was again to inhibit the resorption that was going along with the cancer, and to prevent that in several different things, but multiple myeloma and metastatic bone cancers. Fosamax, that's a big one. That's a multi-billion-dollar drug. I mean, I think now it's no longer patented, so it wasn't making as much, but I think in 2005 it made like $3 billion or 3-point-something billion dollars. I mean, enormous, enormous earning for Novartis, I believe is the company that makes it. So Fosamax, again, is a very big drug, very common that we see. That's an oral medication. Actonel is the second most common prescribed drug to treat osteoporosis and osteopenia, and we'll talk about what osteopenia is. And then Boniva is one of the more recent bisphosphonates that was introduced in April, I believe, of 2006. And that's the nice thing about Boniva is it's a monthly dose. You don't have to take a pill every single day or twice a day. You just take one. And then there's another medication, which is more recent, called Reclast, which was approved in 2007. And instead of taking it monthly, you get it yearly. So you come in, you get a shot once a year, and then you're good to go, right? Oftentimes, this medicine has been used more to prevent osteoporosis in patients who are being taking steroid medications for arthritis. So if you have other reasons to be taking steroids, then oftentimes they'll use this along with that. So Reclast has been, I've seen that a little bit more often with that. The cost of this is about $1,300 a year. So the one-time shot's $1,300, not cheap. So what do the bisphosphonates do? Well, I mean, we can get into a lot of detail in regards to the molecular level of what goes on and how it affects. But basically, overall, what it does is it inhibits bone resorption, okay? So normally, our bone, you know, you look at bone, most of the time you look at it and you think, well, it's just always there. But actually, bone is always changing. There's always going to be adding and remodeling and changing, so that there's osteoblasts and osteoclasts that are in a constant flux as far as adding bone and subtracting bone, and that's normal. That's exactly what we want to have, and a lot of that's based on function. Okay, so I mean, if you need, if you have areas that have higher function, then you're going to have a lot more activity in some of these places. So the bisphosphonate medications are designed to inhibit some of that bone resorption. So they sort of attack osteoclasts. Osteoclasts are what resorb that bone. So that's what the bisphosphonate medications are designed to do. And repeated doses of these bisphosphonates can accumulate in the bone matrix and can be toxic to the osteoclast. So they affect apoptosis. They affect how those osteoclasts die. And normal cell death is normal. You know, you get osteoclasts and they're going to turn over and make new osteoclasts. And over time, the medications will affect you know, how these osteoclasts works. So this does inhibit that normal bone turnover and renewal, and that will reduce the serum calcium levels. So in some regards, that's really good. That's what we want, to reduce some of those serum calcium levels in patients who have really high hypercalcemia of malignancy. So that's what they're doing, is they're really killing the osteoclasts, and that leads to this not functioning as well. So understand with this slide, this isn't a direct correlation. This doesn't give you numbers like, okay, you have 1 here and you have 4 here and this one's like 57. This is just a schematic to say that over time, that bisphosphonate toxicity is dose and time dependent, which means that if you have a patient who's been taking oral bisphosphonates for a year, it takes a while for the medication to really kind of build up there. So if it's been taking it for a year, you have less of the medication around than as you do as someone who's been taking it for over 5 years. So again, this is, you can't do I certainly don't know the direct correlation of what number or what amount the you know, the bisphosphonate amount is at 5 years, and that's going to be dependent on the patient, you know, and depending on the other things they have going along with it. If they're taking steroids along with it, if they have other, you know, every patient is different in how they'll accumulate these medicines. But in comparison, just looking at the schematic picture, is that, you know, for IV bisphosphonates, obviously it shows it goes a lot quicker. You know, you go from 1 to 3 months to over a year, and you get a much higher accumulation of that medication within the bone, affecting the osteoclast. Okay, in oral bisphosphonates, it takes longer. So here, you know, you go from 1 month here to a year. Here you go from a year to 5 years. So oral bisphosphonates takes a little bit longer. That's the take-home message with this picture here. So the buildup with the IV bisphosphonates certainly is a lot quicker. So again, what are the indications that we talked about? Well, osteoporosis and osteopenia. We'll talk about what osteopenia is. Paget's disease, multiple myeloma, and then some of the cancers that we deal with. And metastatic breast cancer is very common. Most of the patients that I see, as far as who have been taking IV bisphosphonate medications, are usually breast cancer patients or multiple myeloma patients. So there are a few other uses for bisphosphonate medications. You know, there's a list of those that we can use those for. They're not necessarily what they're off-label uses, which is fine, but they have their role there. So as far as when was this first discussed? Well, first time that we see this in the literature is something they called phosphajaw. They had people who were working in the phosphate mines, and they were making matches, and they would find that patients would have dead bone. I mean, they'd come in and their lower jaw would be exposed, just like we'd see that in our bisphosphonate patients. And you know, you'd have these very big dehiscent wounds with dead necrotic bone right there, and so that was kind of where it was first reported. And you know, I mean, it was a small number of patients who had it, and it really kind of you know, didn't take off as being that, you know, but this is where we first saw it, was in the British Medical Journal in 1899, where we first kind of introduced that. As far as what we see now is that, you know, and that stands for bisphosphonate-induced osteonecrosis of the jaw. This is Dr. Marks. I've met Dr. Marks several times, and so Dr. Marks and Dr. Sal Ruggiero were two investigators who very early on saw as and we found that more in the IV medications, like Iridia was one of the first ones that was really talked about, but in the IV medication patients, they saw just a larger number of people. The cases just kept coming in, and they were trying to figure out, well, why do these people have these dehiscent wounds with bone exposed? And so Dr. Marks in Florida was able to kind of put together that, oh, well, they have, here's the common theme. So it's kind of like being a detective. And as he goes through and looks at it, he says, well, every one of these guys is taking these bisphosphonate medications. So he put out a paper, or they started studying this in 2002. They put out a paper in 2003 in the Journal of Oral Maxillofacial Surgery, and there was 36 cases that were related to Aridia or Zamida. Those were the IV bisphosphonate medications. And that's really what you saw, is you saw patients who came in and they had this little exposed area bone down here, and it just didn't go away. It was there for weeks and weeks and weeks and months, and some patients had pain, some patients had infections, some patients were really, really bad. They had oral cutaneous fistulas where they had openings down here where pus was coming out of the jaw. Some patients came in with pathological fractures. I mean, the jaw had already broken. So we were trying to see what was going on, and this was one of the first ones, big ones in our literature. And then Sal Ruggiero up in New York also came out within 6 months and also was studying the same thing. So they were both seeing that and correlating their findings. So it's a rare, but it's definitely a problem. Fortunately, again, we talked about it being time dependent and dose dependent. So patients who have been on these medications for 7, 10, 12 years for the oral bisphosphonates, patients who've been on certainly the IV bisphosphonates for over a year certainly have a much higher risk of having major kind of issues. Fortunately, most of these can be treated to a resolution, which is great. However, they can represent one of the most challenging oral pathologies that can be very, very devastating. This picture right here is this is actually Roger Ebert. He actually had oral cancer. This was not from a bisphosphonate medication, but he lost his whole lower jaw. And you can just really see, I don't know if you remember Ebert, but he was like this big, huge, like, guy ate everything in sight, and big, healthy fella, and then you see what he got with oral cancers, and he lost his whole jaw, lost all that, and just really, really devastating. And some of these bisphosphonate type cases can be very, very similar, is that they can have severe type of effects. In this case, you can kind of see this is the neck, there's the mouth, and so a big incision was made around the neck right here, and all this area was taken out. So the condyle of the mandible all the way across over here to where this bone is at, that was all taken out just because of dead bone. And there was really nothing we could do about it. There was this little thin thing that was just fractured, and it was just a mess, So these can be very, very devastating. This picture is more of a person who has osteoradionecrosis, which means that they had radiation due to their cancer as well. But you can kind of see, I've seen a couple patients who have had openings in their lower jaw that you could actually see the bone in underneath there. So it said some of these can be very, very severe. And the idea is not to scare you with horrible pictures, but just to let you know that they're there, and some of these are very, very challenging to fix. So what is this? The definition that we use now is that if you have exposed non-healing bone in the maxilla or the mandible and has to be present for greater than 8 weeks in a patient who has received systemic bisphosphonates, either oral or IV form, and no history of radiation treatment. If you have radiation treatment, that's a different subset of patients because and they'll respond differently to different treatments. So a bisphosphonate group of patients have never had radiation to the head and neck area. So that's an important determination there. So as I said, Novartis notified healthcare providers of these kind of precautions with their IV bisphosphonates in 2004. So 2002 is where we kind of accumulated a lot of these cases. 2003, we started making reports on it. There was a heck of a lot. There was very few reports in the early 2003, 2004, but Novartis came on and pretty quickly and kind of gave a list of precautions to saying, okay, if you take this medication, you could potentially have areas of necrotic bone. And then they increased that to a broader drug warnings to include the oral stuff in 2005. So we've known about this for a little while, and the information is out there for patients to understand. So when you look at areas that show, I mean, these are real live patients who we've seen in different ways. I mean, you'll have little areas. This is a very common spot to have an exposure here. You have the same thing over here that's on the lingual portion of that mandible, very common there. Again, right over here, this one's a little bit bigger, and you can have it up in the maxilla as well. So you can look at that bone, you can see that's just not healthy bone. That's dead, yucky bone. So that's a little bit bigger again on the maxilla. And these are really, really tough because you have a person who's had a wonderful restoration. They've been functioning just fine with those kind of implant-supported restoration for many years. And you know, this is all gone. You know, you have to take out this, and you end up taking out a large portion of the maxilla to treat that. So these are tough cases to kind of fix. So the drug companies will report about a 1%, about 1.5% incidence of getting bisphosphonate-induced osteonecrosis of the jaw with IV form. That's what they'll report. Independent studies have shown that's a lot higher than that, you know, and I certainly have seen a number of patients who have been on these medications who certainly do come in with exposed bone. Not all of them are super severe. I mean, some of them are just small little areas, which is fine. But I think that the incidence of what the drug companies report to you and what the incidence of what we've found in the literature is probably somewhere in the middle, you know, somewhere, you know, so still with Fosamax, which is very big drug that's used quite often, it's still less than 1% of those patients will get exposed bone from that. So that's good. That and it's good. The IV cases are certainly more severe and more common. So that's nothing new. So when you look at the articles published over time, you can see 2003, not too many, you know, just a couple people doing it. But as time has gone by, you can see that that's really increased. I mean, in 2008, 2009, 2011, I mean, these numbers are much higher, you know. I mean, and I tried to keep up with the literature, but I couldn't read all that many articles. There's tons of different articles coming out discussing what to do. The good thing is that, you know, the problem is noticed. The bad thing is one person will give you one set of advice, another person will give you another set of advice, and some of them are molecular studies, which is great, so we understand that things at a higher level. Some of them are just case studies. Say, hey, you know, I had this, and the patient came in, and I threw some of this on there, and it worked. So you have to really kind of go through this and really take a look at what's going on. And I'm going to go over sort of I'm going to go over a couple things. We'll go over kind of more the conservative type treatment of what the American Association of Oral Maxillofacial Surgeons sort of suggest doing, and then talk about some things we're doing that is more aggressive. I mean, surgeons don't tend to sit still. We're not people who want to sit and have people come in and look at it and go, yeah, we'll just leave that alone. And a lot of times that's what we say to do. Just leave that alone, that'll get better. Just by nature, that's not really our personality. So there's a fair number of more articles in the recent years, in 2009 and to now, where we are kind of being more aggressive with conservative type cases to try to treat those early so they don't turn into the big messes that can happen. And we've had some interesting results with it. So I think those are promising. So why do we get it in the jaws versus long bone or versus, you know, a femur or something like that? Well, it can, I suppose, happen anywhere, but where we see it, where the dental community is going to see this, is because our bone in the jaws will renew about twice a year, about twice in a year's time period. We'll get the alveolar bone will kind of renew itself. The exposed bone first develops in the alveolar process because this is the area that has that high level of turnover. So you have a lot of osteoclasts and a lot of osteoblasts and a lot of turnover in that area. And the reason is we're always chewing, we're always functioning, we're always talking, we're always doing things to put functional forces on the teeth around that alveolar process. So we have a very high turnover rate in that region. So, you know, the alveolar region really has a much greater uptake of the medications that we use because of that high turnover. So, so that leads to higher concentrations of the bisphosphonate medications in that alveolar bone, and that's oftentimes that's the reason the alveolar process really gets exposed a lot more. The mandible is much more common than the maxilla as far as being exposed, but both of the areas can certainly have that. So there's some early signs that we can see on some X-rays. So and these are hard to find. I mean, good luck if you can find this. If you can see it, you're a much better clinician than I am. But you know, a lot of what you're going to find out with these patients is going to be done on clinical history. Is a good history and physical, asking questions. You know, you know, a lot of times patients won't give you that information right off until you start asking questions. When you start asking questions, they'll give you more information. But you can see some things, like you can get a widened PDL, you can get sclerosis of the lamina dura, you can have some mobile teeth, and you can have pain. And most of the time that's kind of a deep pain, and it's not explained by some other reason, like a cavity or something else going on there. So in these pictures you can kind of see that, yeah, it's hard with the lights on, but I mean, there's a little bit of a widened PDL around this area right here. You can get kind of like sclerotic areas around here. You know, if I didn't know I was looking for that in that specific patient, I wouldn't necessarily look at that and go, oh, I'm really concerned about that. So again, using a clinical correlation with your good history and physical can really kind of give you some information. Most of the time, we're not going to find this before it shows up as a, you know, as an exposed bone in the mouth. If you can find it, good for you. That's great. You can get some generalized sclerosis within the area. That can be indicative of other things too, right? I mean, there's other kind of disease pathology that can go along with that. So again, you have to correlate that with, you know, with your history and physical. These can be pretty devastating when they come in. You can get a pathological fracture, and this segment right here should be down here. So someone came in, they had a big broken bone. So that's a little bit more obvious. I can find that one. I'm like, yeah, I got that one. One of the things that we look at is that we actually have sort of a genetic analog to what is going on with the osteoclasts in a specific disease. So osteopenia, or osteopetrosis, I'm sorry. Osteopetrosis really is a problem with the osteoclasts without taking any medications. These are patients who just have this disease, and it shows that there's a dysfunction of that osteoclast. So we've used this as a bit of a model to kind of figure out, well, this is what's going on in this disease. These are the problems that they have. How's that, you know, how can we apply that to the bisphosphonates? So when you look at osteopetrosis, these guys don't live forever. These guys have a shorter lifespan for sure. There are different phenotypes of this. There's more milder forms of the disease. I think Albers-Schonenberg was a disease that is a milder form of it. Most patients usually are really short, and their growth, their bone growth has been affected because they don't have good remodeling and turnover of the bone. The bone becomes very hypermineralized, which means, you know, more and more bone is added, so it gets really, really dense. And you commonly, in these people, you'll see fractures. You'll get non-union, so they'll get a fracture, and then it doesn't heal right, so the bone doesn't heal as it should. And you'll get, within the cranial nerves, as things are growing, the foramina, or the holes that are in there, actually they should remodel and change as people are growing, and they don't, because they just don't have that osteoclastic activity. And so you'll get hearing loss, you'll get facial palsies, which this little kid has, and then oftentimes they'll have a lot of pain, and they can affect their vision as well. So I mean, this is someone, obviously an adult, but you can see, I mean, that's a lot of bone. I mean, that's a bony head. I mean, I don't see any trabecular patterns. I don't see any kind of medullary space. I don't see any of that kind of stuff going on there. So this is someone with osteopetrosis. So, you know, that can progress. They get other kind of problems. They get problems with their with the bone marrow spaces, because that gets obliterated, and so they get anemia. They get problems with their white blood cell counts and their red blood cell counts, and they get a decrease in calcium. So these patients can have some significant issues. I don't know if any of you guys have ever seen patients like this. Most of the time, I don't see them as kids. Sometimes I've seen a couple as an adult. But you can get over-retention of the primary teeth. You can get non-eruption of permanent teeth. You can get exposed non-healing alveolar bone, just like we see in the bisphosphonate groups of patients. And these guys, debridement is horrible. I mean, if they have a diagnosis of osteopetrosis, you know, you don't operate those. I mean, because no matter what you do, it just makes it worse. So I mean, you have a very difficult time. I mean, I may take out like a little piece of bone that I can kind of like tease out, but I don't make incisions and open things up and tear. I mean, because it just all turns into a mess. So debridement attempts really do make these a lot worse. But they can have secondary infections and orocutaneous fistulas when they come in to see me as well. So these are difficult things to fix. very high functioning, wonderful, nice lady has got just really bad disease. I mean, all that's just exposed bone. That should have gum tissue and everything over top of it, and it's not there. And what that is, that's a Band-Aid that's covering an opening that having pus come from the inside of the mouth to the outside. So as I said, these are difficult ones. So in these patients, what we've kind of gone over is you avoid any kind of invasive dental procedures. You try not to do any extractions if you can avoid those. Oftentimes what you can do is you can do a root canal, put a little bit of gutta-percha material down at the bottom, and then take that crown and just zip it off. Just cut off the crown part of that tooth. You can, if there's some mobile teeth, you can splint those together to help maintain those. I mean, oftentimes you're going to lose the tooth eventually, but let the tooth fall out on its own versus doing something more invasive. That doesn't mean that don't do dental procedures. I mean, if you've got a cavity, fix the cavity. If you have a, if you need to do a root canal, do a root canal. Do the things you normally would do. Do routine dental procedures, but avoid surgical type procedures, and really sort of opening that area up and doing, thorough debridement and gum surgery. And I wouldn't suggest that not on these patients. And then it's important to inform the patients that exposed bone's permanent. That's not going to go away, and that surgery will increase problems with that. So that's one of the things we usually do with those. But you do need to manage the secondary infection. So oftentimes you give them some Paradex, and you'll give them some penicillin or the appropriate antibiotic, and just kind of move them along as best you can. I said these guys are very tough to make better. So there's really no medical treatment that reverses or slows the disease. We do have certain medications that we do give these patients. They do have a shortened lifespan. The oldest known survivor was 56 years old that I know of that was reported. The mainstays of treatment are really preventing and managing a lot of the complications, and they require blood transfusions. They get anemia medications. They get calcium supplementations. The scary part is, if they have to have surgery somewhere else in their body, just doing a simple intubation, where you actually, move their neck back in order to do an intubation, that can actually cause someone to be a quadriplegic, because you can get a fracture right there and it affects their spinal cord. And we've had mandible fractures. Actually, one of my partners actually treated a mandible fracture on a patient who had this, and they just did a simple intubation for I don't remember what it was for. I don't remember what the procedure was, but it had nothing to do with the face at all. It was something down here. So let's look at the IV bisphosphonate-induced osteonecrosis. So those are patients who obviously have some more issues here. So intravenous use, so you have an exposed non-healing bone greater than 8 weeks, like we talked about, in a patient who has been taking the bisphosphonate medications, who doesn't have a history of any radiation, okay? It's based on clinical evidence, not a radiograph or histology. You don't have to send something in, take a biopsy, and send that off. I mean, basically, if someone comes in, they have exposed bone, they fit that criteria, then that's bisphosphonate-induced osteonecrosis of the jaw. I mean, that's kind of where that fits in. The onset really is related to the potency and the half-life of the bisphosphonate used. So as I said, if you're taking these medications, you're taking those IV medications for longer periods of time, it doesn't take a whole long time. It takes 4 or 5 doses, and you really do have levels that can cause these things here. So the half-life of some of these medications is really long. It's like 10 years, 10, 11 years. I mean, these stay around quite a while, even when we're not using them. So the big ones that tend to show up as far as use, because they're very, very good. They work very, very well in these patients. Again, I'm not trying to say that these medicines are not good. These are very important medicines that provide wonderful improvement in quality of life for these patients. However, they can have the side effects that we're talking about. So Zometa is the most potent, and it can produce exposed bone in about 6 to 12 months. Iridia's usually is about 10 to 16 months where it can. It doesn't mean it will, but it can. Primary indications for these, again, were multiple myeloma, metastatic breast cancers, and metastatic prostate cancers. This guy here is a person with multiple myeloma. They have these little punched out lesions within the skull. They have them in other places as well. And this is actually metastatic prostate cancer that actually shows up in the hip. So here's a bunch of percentages that I'm not going to test John later, but it gives you an overall idea of what's going on. So for the IV medication users, 25% of these lesions will develop on their own. So which means you didn't have surgery, you didn't have a dental procedure, you didn't have anything that goes along with it. They just showed up and they showed up. You know, so that's a spontaneous exposure. 75% of them are usually precipitated by some sort of invasive dental procedure. Most of the time it's a tooth extraction, right? They needed to have a tooth taken out. They'd been on these medications. You take out the tooth. You know, 36% of those were initiated by a tooth removal. 31 presented with no symptoms at all. So, you know, it came out of nowhere and they didn't have any symptoms. It's just, I have this exposed bone, and maybe they were seeing their hygienist, or they were seeing their dentist, or they were seeing someone who looked in their mouth and said, hey, what's this little area right here? And they told them about it. So that's not an uncommon presentation, but 69% did present with some sort of bone exposure and pain. Okay, you had pain associated with that. The mandible accounts for more of them, right? 68% of the cases are in the mandible. The maxilla is about 28%, and 4% occurred in both areas at the same time. So most of the time you don't get them in both at the same time, but you can. The molar area was the most common, about 88%. The lower molar was the most common. So, you know, number 18, 19 was their most common areas. That region was the most common. Upper molar is about 23%. So once the bone is exposed, you can expect that to remain exposed even if you stop the medication. Okay, so they were taking the medication, they stopped the medication, you wait 5 years, is the bone exposure going to be there? Yeah, more than likely it's still there. It's not going to go away. Traditional attempts at local debridement have tended to result in additional exposed bone and worsening of the symptoms. And I'll talk a little bit about that on why that may be, why we've attacked it a little different way, and maybe we'll get some better results with that. But certain comorbidities will certainly shorten the time of onset, so especially in patients who are taking corticosteroids at the same time. Yeah, I mean, if you have a patient who's taking bisphosphonates, they're on corticosteroids at the same time, boy, that raises a big flag. Those comorbidities really kind of increase the rate of progression and how severe that these can become. So there are certainly other comorbidities that kind of go along with that. I mean, obviously they're taking these IV bisphosphonates for a reason. That's for cancer. Often, you know, multiple myeloma or cancer problems. You know, that cancer in itself is really, that's not a healthy thing to have. That's really not something you want. So that in itself can cause some problems, and you can get some syndromes that go along with that. Problems with the cancer. Oftentimes, as we treat those, we're treating them with chemotherapy, right? So the chemotherapy, that's not going to make you any healthier. Hopefully, that's going to help take out the cancer cells a little bit quicker than it takes out the real cells, or not the real cells, but the healthy ones. But that's what we're doing with chemos. We're trying to like take out the bad stuff quicker than we take out the good stuff. I mean, that's really what we're trying to do with chemo. Chemo is not a pleasant thing to go through. I mean, I don't know if anyone's ever gone through that or had family that's gone through it, but it's very difficult, very, very difficult thing to go through. So again, that's another medical comorbidity that can certainly cause more problems. As I said, steroid therapy, 55% of the patients who are on both the IV bisphosphonates and the steroids can show up with this problem. So again, you know, someone who's on chronic long-term steroids will have other problems aside from just this, but certainly steroids can help with that. Methotrexate is a cancer drug, but we also use it in rheumatoid arthritis. We use it in other kind of reasons. So that's if someone's on methotrexate, that can have an added increased problems and other comorbidities. So I mean, patients with diabetes, obviously they have problems with wound healing just to begin with. Smokers definitely have a bigger problem. Rheumatoid arthritis, they're on a whole, and systemic lupus, those guys are on medications anyway. And there's a whole bunch of medications that go in and out with these guys. So sometimes they're on methotrexate, sometimes they're on steroids, sometimes they're on these other kind of medicines, and they all can kind of add to the mix as far as making these things a little bit more difficult. So the dental comorbidities actually play a little bit more significant role than some of the other parts. You know, I mean, aside from the steroids, if a person comes in and has something going on that provokes some sort of inflammatory bone response, normally what we're going to do is we're going to manage that with our osteoblasts and our osteoclasts, and they're going to kind of deal with that. But you know, now that we've taken these medicines and kind of knocked out the osteoclasts, we don't have that normal bone turnover. We don't have that normal metabolism going on. So patients who have active periodontitis, you know, 84% of those patients, That's not good, right? Dental caries, dental abscess, an abscess, failing root canals, tori. Tori are notorious for just being, this is a very if someone has big tori in there and you know they're going to be giving IV bisphosphonates, those go, get rid of them. You know, send them to a surgeon, send them to someone, or do them, you know, do something to get rid of those tori. Those tori are a very common place for those to show up. You'll see them a lot down here, but a lot of times you'll see this, and you'll see that on that that medial portion of that mandible back there on the lingual side, right next to an area of a tori. So very common place to get that. So with these, when people come in and they have active periodontal disease, they have cavities, they have that are causing caries that go down into the pulp, they have an abscess going on, they have a failing root canal. Fix those before we start these medicines. You know, it's one of the important things, and that's where we've really done a much better job now than we have before, is kind of coordinating with our medical community. You know, we try very hard to coordinate with the, you know, with our docs, saying, look, we know that this medication is very important. We want that, you know, we know you're going to put these on there. Let me fix this dental stuff before you start these medicines. And you can really, you have a time frame to do it. I mean, you really doesn't all have to be done day one to say, okay, don't start this, you know, until this day. But, you know, I mean, you have a window. You have and I can't give you an exact number, but you have about a 3 to 4 or 5 month window where you can really kind of take care of those things before those levels of the bisphosphonates really get high enough that they're really going to cause a whole lot of problems. So very important that we kind of work with our, you know, with our internal medicine docs and our cancer docs, and just say, look, if you're going to use these medications, send them over for a routine exam and let us look at those. And if you see, and these are ones you want to treatment plan really aggressively. These are not patients who you look at and, well, we can watch this for a while. If there's any doubt, if you even look at it and go, well, it could work, could not work, gone. Get rid of the tooth. Don't even think twice about it, because you can fix. You can take out that potential area that can turn into a mess later. You know, so definitely treatment plan these aggressively. Find a wonderful endodontist, or if you do your own root canals, do something to take care. Anything that looks even close to the pulp needs a root canal, needs to come out. I mean, really, get rid of those things that could be a potential source of one of these areas that can cause a lot of the dead bone there. So I would just be very aggressive with treatment planning these. If you see tori, I'd get rid of them. Just, you know, in those IV bisphosphonate patients, I would get rid of those quick. So we've gone through different kind of levels of staging these. We have a 1, 2, 3, and then we kind of subdivided those into A, B based on size. But we're trying to, over time, we've been trying to figure out how to, a stage that says, okay, well, if we see this, we're going to treat it this way because we get a good result, or we get a better result. So this is the staging system that we currently use. So you have patients who are stage 0, which means they don't have any exposed bone at all, but they potentially are at risk because they've been taking IV bisphosphonates for a longer period of time. So those are kind of stage 0, you don't see any exposed bone. A stage 1 person actually has exposed bone, but it doesn't hurt, and it's not infected, okay, which is good. So normally, you know, stage 1 is less than 1 centimeter. When you talk about stage 2, you do have exposed bone, like you know, just like in a stage 1, but you have pain associated with it, and or you have some sort of infection going along with it. So you have, you know, red outline, potentially you have pus, you have erythema, you have edema, you have other things going on in there. But it hasn't gotten as bad as our stage 3. And then you have an A and B where, you know, they talk about 2 centimeters. Stage 3 is really where you have multiple areas of exposed bone, and you can develop oral cutaneous fistulas, which means, you know, you have purulence coming out on the skin and pathological fractures. And then oftentimes you can see evidence of osteolysis down on that inferior border going all the way down to the bottom of the mandible, so, or the inferior border of the mandible. So those are our stages, right? You have stage 1, stage 2, stage 3. I usually don't divide it into A and B based on size. I just go 1, 2, 3 based on what I see. But certainly this is the detailed staging of how you would look at that. So when you look at someone who's stage 1, right? I mean, it's very small, doesn't hurt, little tiny exposed areas, probably at less than a centimeter. So there's stage 1, and hey, look at that, there's a tori right next to it. So here's one that's has painless exposed bone. It's a little bit greater than centimeters. That could be maybe that's still a 1 because it doesn't hurt and doesn't, it maybe has a little redness right there. So maybe you can probably put it in stage 2, but that's between a 1 and a 2. Here's like a stage 2 where now you have pain and you have these exposed bones. So you have bone here that's a little bit bigger than what we saw before. Probably that came from an extraction site. And they got pain, it's infected. This is the maxilla up here, and it's very infected and angry. And this is actually right here, this is that large tori. That's a large maxillary tori that's exposed. So again, more stage 2, a little bit bigger, infection going on. Stage 3 can be quite extensive. I mean, someone comes in like that, ooh, that's ugly. I mean, in order to get rid of all that, if I have to, that's a maxillectomy. I mean, I'm really taking off most of the maxilla in order to treat that. So these can be very big, right? I mean, this is the sinus right here. So you've lost all this bone right here. You've eroded into the sinus right here. And again, those are not easy fixes. So here's an X-ray with someone who has significant osteolysis, which means there's still problems going down on the inferior border. I mean, this is a pathological fracture that's just going to happen at some point, so you can kind of see here's bone right here, here's the tooth. You've lost all this bone right here, and all this is just kind of dead bone right down toward the inferior border. So a lot of times these guys will come in with numbness. They'll say, I have paresthesia. They'll have oral cutaneous fistulas. They'll have all these other kind of big things. So these guys are troublesome. I mean, you can see here you have a nice sequestrum of bone right here. This bone is all surrounded right here, but this area right here is really, that's all dead bone. And here's multiple areas right here. So you have several different areas. Sorry, I didn't show up great on the lights on. So again, I mean, here's a patient who has, multiple areas where you have, all this dead bone down here, and you have, orocutaneous fistula. This is obviously a different patient because there's a plate right here, so someone's already treated that by putting a plate on there, and that's just eroded out. So pathological fractures happen as well. So what do we do, with these guys? So you want to avoid the need for any invasive dental surgery after the bisphosphonate treatment is initiated. I said you may have a little window of a time, several months, that you can kind of get things done. But 75% of these develop due to some surgical or dental trauma, right? I mean, hopefully I'm a little bit less, less rough than that. But even if you're really, really gentle in taking out teeth, the surgery is not wonderful for these patients often. So dental assessment and removal of any abscessed or non-restorable teeth is really important before you start. So I said it's important for us to really develop a good relationship with our internal medicine docs and get a good relationship with our cancer docs and say, look, I mean, I know that you want to put these patients on these medications. That's great, and we understand your reasons for doing that, but let me treat any of those teeth. And it's very important when patients come in and see me, or if they've been referred to me because we need to get these out, I sometimes I pull out a few pictures and I say, look, I know that cost is an issue, and this is an issue, and this is an issue, but I mean, when you look at the potential devastating effects that these can have, I mean, really, let's work with your costs. That's fine, but this tooth is not a savable tooth. It's gone. This tooth is not something you're going to work with. I mean, I would take out this tooth, and in the end, they may get 8 teeth that may or may not have been something you could have done periodontal surgery on. You could have done things on. But I'm just saying, take them out. Just get rid of these darn things because they can potentially turn into a big mess. So I'm far more aggressive in treatment planning these, and when you work with these kind of patients, and that sounds like a lot, especially for if you haven't seen a lot of these patients coming through, but you're doing them a much better service by being aggressive, by treating some of these things, by doing root canals on teeth that are, maybe you wouldn't have done a root canal on, or I'm not just saying if you have a little tiny thing to do a root canal on it, but treat what you need to treat. I mean, I'm not saying be any different than being a dentist of what you've been doing, but if there's a tooth that's questionable, it goes. If there's a cavity that needs to get filled, it's fill it. If there's something that needs to get done, do that now before that really kind of adds up. Okay, so I would be aggressive with your dental treatment planning. Impacted teeth with no intraoral communication. So if you have an impacted tooth that's sitting way down here, doesn't have any intraoral communication, It can be left. You know, we've had several studies that show, you know, that most of the time those don't show up as any problem, but can they? Yeah. And so I usually tell the patient, say, look, likely this will never be a problem, but if this does get exposed, you know, and later on, if you have, you know, an exposed tooth, if you have a tooth that's way down, like a third molar, and they put a denture on there later on, the denture kind of rubs on the top there and it can get exposed. Those are hard, you know. Do you take it out? You don't take it out. It's a juggling trick. Most of the time, again, I'm more aggressive with extracting teeth, especially if they haven't started their bisphosphonate medication. So if I think there might be a problem, I take it out. If you have large or multiloculated tori like this guy right down here, those got to go. You got to get rid of those things. They are particularly prone to getting, you know, poor vascular supply through there, and that thin overlying mucosa can just wear away really quick. They have, you know, patients who have cancer have an increased risk of having problems. Patients who have diabetes have increased risks of having poor wound healing. So, you know, you have to add those comorbidities along with that. Oftentimes we'll use antibiotics beforehand, and there's been plenty of studies that show we kind of keep the antibiotics going on for a little bit longer. So I may have especially if they've already been taking these medicines, I may keep them on antibiotics for 2 or 3 weeks, you know, just to potentially avoid a problem. Does that always avoid a problem? No, it doesn't. So, you know, here's some more pictures you can see. I mean, the tori like that, you got to smooth that off. I mean, that's really not going to be great. I mean, that can turn into this pretty quick, and that can be difficult to manage afterwards. You know, these tori I would get rid of because this guy turns into that, and that's harder. That's harder to fix later on down the road. So dentally, you know, what do we do to prevent these things during treatment? So they've already started their IV medications. Well, maintain optimal health as best you can. Non-restorable teeth should be treated with root canal therapy, and you do crown amputations rather than removal. This isn't for someone who is beforehand. This isn't pre. This is someone who's in the middle of it, right? They've been taking these IV bisphosphonates for a while. You can splint those mobile teeth. You can do routine, I don't see this as much as when we first started talking about these things, but some dentists just won't treat the patient. Say, look, I'm not even going to look at you. You come in, you have a cavity, I'm not doing a thing. You don't want to do that. I said these patients you definitely need to see, and you can perform routine treatment on them. You can perform routine restorative care. You can do prophylactic cleanings. I wouldn't do big periodontal surgeries where you're pulling back the gums and doing a bunch of bone grafting and things of that nature, but certainly routine care on these is just fine. You know, you're not going to have problems with routine care. If you're doing surgery on them, that's a little bit more invasive. So I mean, oftentimes you'll want to kind of share the risks and for the lawsuits down the road, and let your oral surgeon get in there, or let your periodontist or someone who does surgeries a little bit more, who knows these patients and how to deal with them. And deal with the problems with that as far as doing surgeries. But if someone comes in, they've been taking IV bisphosphonates, bisphosphonate therapy, and they have an abscess tooth that's pussing out, do you ignore that? No, you can't ignore that. You have to take that out. And so oftentimes they'll get sent to me, and what I'll do, I'll take the tooth out. I just go over things in detail with them and say, look, here's what we know, here's the medicines that you're on, we have to treat this tooth. Can this turn into an area where you have poor bone turnover? Yes, it can. And oftentimes, when I take out a tooth, I'm a little bit more aggressive. I take out the tooth, I'm not aggressive with the extraction part itself, but I'm going to take away a little of that bone too. You know, I'm going to remodel that bone a little bit so I can get good primary coverage without any sort of pull on there, any sort of tension on the wound. So, you know, I said I might be a little bit more aggressive in treating those, in doing those extractions, but I don't. You can't not treat these patients. I mean, these patients really need to be seen, and if we don't treat that, that's when it really turns into a mess. So definitely treat the patients, and do what you would normally do if they're in, if they've already been taking these medicines. Do what you normally do, but don't be aggressive with surgical type procedures if you can avoid it. Existing periodontal disease should be treated non-surgically. You can do supragingival scaling and use Paradex. Assess the denture for any pressure areas that can lead to ulcerations, and kind of adjust those. That's fine. Abscess teeth need to be removed. Oftentimes I put them on antibiotics for a month or a while. And I also do a really good informed consent, telling them, these things can turn into necrotic bone. So the oral maxillofacial surgery community really, our established treatment of patients who have been on these IV drugs really is exposed bone is, we tell them, exposed bone is likely to be permanent. It's probably not going to go away. Attempts at debridement oftentimes have made the situation worse and increase the chance that you can get a fracture. And this is the stuff that I tell the patients. And we want to prevent and control secondary infection and type pain. So exposed bone itself is, if it's not painful, the exposed bone itself really doesn't really hurt because there's where the nerve receptors is in the periosteal layer. So we've kind of lost that periosteal layer, and so we've lost that innervation. But where the pain and inflammation comes from is from that secondary infection of the bacteria that's surrounding those areas. So that's why the patients are having pain. It's not necessarily because the bone is exposed. It's because of those areas around there are mounting an inflammatory reaction. That's what's causing the discomfort. And if you get an infection there, it hurts. So there has been a fair amount of study on bacterial biofilms and what bacteria potentially can lead to this. One of the guys in USC has made about 5 or 10 papers or something like that. He's had a fair amount of papers out there. There's other labs looking at this as well. They are an area of study, and some recent findings have suggested that that bacteria certainly play a role within, with the development of bisphosphonate-induced necrosis of the jaw. Actinomyces was the most commonly reported species that we saw in a lot of these, and that's what this is right here. You can kind of see that's the actino look next to bone over here. But there have certainly been other bacteria that are involved in there as well. And as those studies become more sophisticated, they found like multiple species really in there that are causing problems. Most of them are ones that we'll have inside the mouth. Obviously, they're ones that are normal oral flora. But there are some that show up a little bit more than others. So this has been an area of study because potentially this is an area we can affect, right? Potentially if we can treat those particular bugs with specific antibiotics, before we do certain procedures, maybe we can prevent this from going on. So I don't have any particular medicine, give them penicillin, give them amoxicillin, give them clindamycin. I mean, I can't tell you, use this medicine, it's going to be better. So, but we can give you some ideas on things that usually cover most of those bugs. So for, depending on the stages, you can use different medicines. So, Paradex rinses, again, is good for any of these stages. Paradex is a good antibacterial mouthwash that works very, very well. Will it stain teeth? Yes, over time it'll stain teeth. That's kind of like not as much of a concern to me in these patients than maybe in your normal average patient, but definitely Paradex is not a bad medication. Certainly penicillin VK usually is a good drug, so if a patient has ongoing or pain going on or infection going on, then penicillin is not bad. If you have someone who's allergic to that, doxycycline is not bad, levofloxacin, erythromycin is not bad, and metronidazole can be added to gram-negative usage. There have been different studies that show clindamycin doesn't work as well. So we've oftentimes if someone is taking penicillin or is allergic to penicillin, we give them clindamycin. In this case, clindamycin may not be as effective, so that's not usually one of the first-line drugs that we use for someone who's allergic to penicillin. Penicillin itself is a good drug. Amoxicillin itself is a good drug. You can use that. But if they have someone who is allergic to penicillin, then they usually suggest something else like doxycycline or levofloxacin. And if they're on those medicines and they're still having that long-term infection, to increase your coverage of the gram-negative type bugs, then we usually use metronidazole, or Flagyl, very, very cheap. It's inexpensive. If you have someone who uses alcohol, you got to be careful with that. They can get an anabuse reaction, and they don't like that. They'll have severe vomiting. So, but Flagyl is a good drug, and Flagyl and penicillin are drugs that oftentimes I'll use for just normal infections on just a normal patient because it's really less expensive. It's less expensive than clindamycin. If you put someone, a homeless person who comes in who has a big infection, and I work on them and they go home and they have no way to get any kind of antibiotic, oftentimes the hospital, I'll have them give penicillin and Flagyl as a good coverage for them afterwards because the clindamycin is just so expensive. Clindamycin is a wonderful drug. That oftentimes I'll use for my hospital cases, but in some of these patients, we found clindamycin just has not been as effective. So that's one of the things that come out of those studies. So, you know, in the stage 3 patients, we're more aggressive, right? If you have someone who's got a fracture, you got to fix a fracture. If they got a fistula, you got to manage that. So oftentimes those patients, we look at what's going on there, and sometimes they'll get a big whack. We'll take a big chunk of bone off, and we'll end up resecting that whole area. So, you know, this is a patient who's had something just like that. They had a pathological fracture because they had bisphosphonate medications. We took out a big chunk of bone right here, put on a big plate right there, closed it all. You know, there's a big hole. You know, you got a big hole right there, and then we put a plate on there. So, you know, that's a big case. That's there's a lot to do on those patients. So some of the things that we've tried that haven't been really as successful, again, we talked about the clindamycin. Is it a bad drug? No. If you use it, is it a bad thing to do? No, but it just hasn't shown to be as effective. Local debridement, well, with the IV people, not as much. We try to kind of stay away from that if you can avoid that, especially if they're not having pain. HBO stands for hyperbaric oxygen. In our osteoradionecrosis patients who've been irradiated, they actually do respond a little bit better to our HBO therapy. We've done a fair amount of studies on the HBO therapy for the bisphosphonates and haven't seen much of an effect. Some patients, some papers show that it's affected a little bit and it's a little bit positive. Others have shown it's done nothing. So there's really, at this point, there's really nothing that we can say that's, yeah, put these guys in and dive them for 30 dives and see if they get better. We haven't really seen that. Also, stopping the bisphosphonate medications. You know, you need to work very closely with your docs, you know, with your medical physicians. That really shouldn't be done because if you stop the medication, does it go away? No, it still stays there. The half-life for these things is really, really long, and it doesn't necessarily make things better, but it can really affect their quality of life. You know, very, very much so. So, you know, you don't ever just, if someone's on these medications, just say, hey, you know, stop this medication. Work closely with your physician. Your physicians there's a reason they're on there, and the more you talk with them, the more you get a good relationship with these wonderful folks, and then you can get an idea of which patients you're going to put on drug holidays, which ones you're going to stop, which ones really you're just better off leaving them alone. So stopping the medication really isn't something that's going to help a whole lot with these guys. So now let's go to the oral ones. I'll try to move along here. So again, the oral doses, again, oftentimes are used for osteoporosis and for treating Paget's disease. You know, certainly there's nitrogen contain. Oftentimes the bisphosphonate medications, they have a different side chain group when you look at the medicine itself, when you look at it chemically, and the ones that have these nitrogen side chains are the ones that tend to show up as showing up as the ones who cause necrosis of the jaw. So Actonel, Fosamax, and Beniva are ones that are very, very common. These right here I haven't seen any kind of reported issues with those with the bisphosphonate medications. So Paget's disease, pretty much it usually affects adults. We don't know why they get them. Basically, it affects, again, their bone turnover. Their bone turnover is accelerated, and you get problems with the bone turnover as well. So oftentimes they're treated with didronel and Skelid, which again are the non-nitrogen containing groups. So those haven't had a whole lot of issues with these two as far as producing the bisphosphonate medications. So sometimes those are decent. That's a patient who has Paget's disease. Osteoporosis, you know, it affects adults, mostly postmenopausal women over the age of 45. 70% of the individuals over the age of 80 have osteoporosis. Caucasian females over 50% lifetime risk of getting a fracture. And again, those fractures, vertebral fractures and hip fractures, these are not good things. There's a reason we have these medicines there to help out, because you know, morbidity and mortality on a hip fracture in a 70, 80-year-old patient is really bad. It's not good. So certainly we want to prevent fractures. Men have a problem with this as well. Men over age 60, 25% have a risk of fractures. Oftentimes what we'll do is we'll do DEXA scans, which will give us an idea of the bone mineral density. In about 2005, there's an estimated over 14 million women in the U.S. who are taking oral bisphosphonates for either osteopenia or for osteoporosis. So, you know, there's a lot of people taking these drugs. So you know, when you look at at the definition, but you can see this is normal bone. That's an osteoporosis bone. I mean, you think that could fracture? Yeah, that can fracture. That fractures a lot easier. So, you know, there are different treatment options that we have for these patients, certainly. Bisphosphonates are one of the things that we choose, you know, that we'll select. But hip fractures aren't so good, and, you know, you get a person who's got, you know, who's got vertebral fractures and has, you know, that's pretty severe. That can get pretty bad. So the bisphosphonate medications that we often use, again, are Fosamax, Actonel, and Boniva. There's a lot of Fosamax out there. You know, half-life for those are pretty long, over 10 years. The Boniva is the one that's a monthly dose, and the reclassed is the one that's kind of a yearly dose. And so you get that's the reclassed. And there have been reported cases of that with reclassed, even though, you know, it just came out in 2007. You know, and by 2008, 2009, we already had cases of exposed bone with that drug. So, so the differences between the oral and the IV drugs, right? Well, you get a longer time of exposure before the exposed bone develops. You get the amount of exposed bone tends to be a little bit smaller in the oral medications, which is good, and the symptoms are usually less severe. I mean, rarely would I see someone who's been on Fosamax for 7 to 8 years come in with oral cutaneous fistulas, fractures, major bone loss. You just don't, you don't see that on those patients. I haven't seen them that bad on those patients. Most of the time, those are the IV patients. So in this patient population, sometimes discontinuing the drug can be helpful. That can lead to gradual improvement, and sometimes you can just get spontaneous healing. You can have that area that it was exposed. You know, you have a stage 1, no pain, no infection, no anything. You hold the drug for a little bit in combination with your medical doctor. You certainly don't do that on your own. And then over time, sometimes that's gone away on its own, which is great. So those can be pretty responsive to either no treatment or just, you know, localized debridement. So this was the picture we showed before, again, showing IV bisphosphonates and oral bisphosphonates and how long it takes for things to go. So, you know, the duration of oral bisphosphonates, if it's greater than 3 years, that's kind of proportionally where you're going to have a problem. And patients who, again, who are using steroids as well, oftentimes for arthritis or some other sort of reason, then those guys kind of tend to have more severe issues. So same set of dental factors that affected the IV people, right? Periodontal disease, you know, cavities leading to an abscess, and then you know, invasive dental treatment, you know, extractions and tori removal and things like that for patients who've been on these for a while can cause the exposed bone. So what do you want to do when you assess these patients? Well, you want to ask them questions. Okay, how, you know, you're taking medicine. A lot of times people don't remember they're taking medicine. They come in, they see a dentist, they go, "You're a dentist. You look at my teeth. You don't look at anything that has to do with my body." So they won't tell you they're on these medicines. I had one of my partners actually did a workup on a patient who didn't tell her a thing about anything that she had to do with the bisphosphonate medications, but she had been taking Fosamax for over 8 years, and she had an orthodontic surgery where we actually, you know, purposely fractured her jaw and moved it into the right spot, and she developed a very, very difficult and challenging way to fix that, and she just didn't tell anyone anything, you know, and we usually do, and she did a wonderful job with her health history and asking her these questions. This patient didn't think that had any relevance to what we do. So ask questions, really ask questions. Try to find out the most information you can from these people. And if they don't give you a wonderful health history, I'll tell you, most of the time, especially if it's an older population, they have a physician. Call them. I'm on the phone with physicians every other day. If I get a patient, I do, you know, 5, 7, 10 consults a day, and every time I get one, I can guarantee you probably every day or two I'm going to get one that I just wasn't happy with my history. I didn't get all the information I needed. I said, okay, well, who's your doctor? I call them on the phone, I chat with them, I have them send them over, and you'd be amazed at what more information you got from the physician, because when they went into the physician, they thought, oh, well, I need to tell these people these things. When you go into the dentist, you go into the hygienist, you go into the dental providers, they don't think anything of it. This isn't attached to the rest of this. You know, for some reason, patients think that way. I don't know why, but it is all attached. You know, it affects everything. So you want to do a good clinical exam. You want to do a good history and physical. If they've been taking these medications, you want to find out how long they've been taking them and the doses that they're taking them. Certainly, you know, the monthly medications are a little bit more And the Reclass and the Beniva are a little bit more aggressive than certainly than some of the other ones. But you want to get an idea how long they've been taking these medicines and what they're on. You want to do a good clinical examination. You can look for widened PDLs. You can look for sclerosis. You can look for tooth mobility and pain. Those are good things to look at. This is pretty controversial. I certainly don't do the serum CTX, but I'm sure some of you guys have heard about that. Dr. Marks, when he put out his book, he really kind of said, hey, CTX is an exam that it's a laboratory test that patients should be fasting, I think, for 12 hours when they go in. But you go in, they take a test, and it gives you, it's supposed to give you an idea of bone turnover, bone metabolism. And that's what it's supposed to do. It's a peptide that is looked at, that shows up in the bone, shows up in the serum, that potentially gives you an idea what's going on with bone turnover. So Dr. Marks gave a list of numbers. He said, well, if it's over 150, then you're better off than if it's under 150. And I'll show you the numbers here. This is not the standard of care. It really isn't. In the beginning, we started doing this a little bit, and I'll tell you, there has been really no wonderful correlative studies that say, if your number is 114, you're safe, or if you're 153 or 310, you're safe to do it. So this is not a safety measurement. It really isn't. And I think Lynn, you were going to talk about that a little bit. Yeah, which is great. I mean, this is. It's something that, as I said, we're doctors, we're healthcare providers. We want to be able to make good clinical choices, and so we're reaching for things. We're saying, okay, well, if I have this, maybe it gives me some indication of whether I'm going to get a good result or a not so good result. So this was one of the laboratory tests that we have tried to use to kind of help us in making decisions on whether to treat or not to treat. So is this a bad test? It's not necessarily a bad test, but it doesn't tell you safe, unsafe. It really doesn't. So there's not, the literature it does not back this up as being definitive in saying treat or don't treat. Can you use this as a guideline to maybe help you out? Yes, you potentially can. I can't tell you whether it's going to be accurate or not. There are patients who have their numbers, I think it's right here. Yeah, there are patients who have their numbers, and I don't buy this slide at all, but this is kind of what was in the book by Dr. Marks. There are patients who have, 50 right here who don't have any problems whatsoever. There are patients who have 500 something who develop this. Can you hang your hat on this test? No, I would not. Is it there as a potential guide if you really if you want to potentially look at this? It's there. Do I use this? No. Would I suggest you use this? I wouldn't. Dr. Mark certainly is a very intelligent individual, and he could go into great detail on what the test is and what it tells you and what it doesn't tell you. So certainly I don't want to say that he's wrong, but I would say that. I will. Yeah, I was going to say the reason he's looking at this. Yeah, he's looking at things to try to have a decision tree. And there are certainly some data that says if your numbers are lower, then they may have a higher problem of that. And I think that correlation's there. However, you can't say that if their number's higher, you don't have a problem. That's not true. Without a doubt, that's not true. So you have to be careful on any of the lab tests that you're looking at. But CTX is a lab test that's been talked about within our literature, and that's something that you can kind of decide on your own whether you want to use that or not. With that being said, do I use this? I don't. I don't use it. So how do you prevent this? Well, you want to remove non-restorable teeth and those tori. 50% of the spontaneous bone exposures are particularly common on that lingual cortex on the lower molar region, like we said, 18, 19, 30, 31 area on that's very common area where that shows up. 50% of those, with these guys are related to some sort of procedure, extraction, some sort of surgery. You can consider intermittent use of the bisphosphonates, which means if you use it for a couple of years, 2 to 3 years, the half-life for those medicines is there for a little bit longer. So potentially their fracture risk, if you put them on a drug holiday for a year, and then they start up again, their fracture risk may not be decreased as much. And again, I would definitely refer to Dr. Kohlmeyer about that. But but this is one of the things that we've done that's very common, is that, you know, they're on the medicines for a year or 2 or 3. You put them on a holiday for about 6 months to a year. You can, and then you do your surgeries, and then they can, you know, wait a little bit longer, and then they can restart those medicines. So that's one way that we've kind of drug holidays have been somewhat successful, I believe. There are alternative drugs that can potentially be used. Again, I don't make this determination. Certainly that's going to be done by the internal medicine doctor and by our osteoporosis doctors as well, and our cancer docs. But certainly for treatment of osteoporosis, there are other medicines that have been effective that are not necessarily bisphosphonate related. So, you know, if you get if there's a patient who's on, you know, a diabetic, COPD, smoker, 85-year-old, person who's got severe osteoporosis and they need to have 15 teeth out, and they've been on these medicines for a while, and you just kind of shake your head and go, well, I can tell you what I can do, and I can do what I can do, but I'm not sure how this is going to turn out. I'll do the best I can, but you have to inform the patients. But potentially those patients, if they weren't taking the bisphosphonate medications and they were taking one of these medications, maybe less of a problem. So that's something to discuss with the physicians as well. So there are alternative medicines that may be helpful for osteoporosis, that are effective, that may not get us into the same kind of issues that we would have with some of these nitrogen-containing bisphosphonate medications. So, you know, there's I mean, very common, you know, right, that area right here, and there's that exposed bone right in that area. That's from an oral, this is a patient from an oral who was taking oral bisphosphonates. I don't remember, I think it was Fosamax or Boniva for, you know, for several years, for about 5-7 years. They've been on it for a while. So are these hard and fast rules? No, but these are protocols that are suggested by the AAOMS. So, you know, oral bisphosphonates for less than 3 years, and you don't have any clinical or radiographic risk factors, you know, you really don't have to change your treatment too much with those patients. Would I still go over with them as far as an informed consent, saying, I'm going to do an extraction, I'm going to do this, going to do this? You know, you're on a medication that could potentially lead to these types of things. Do I expect you to have this problem? No, but these things can happen. So I would give a good informed consent prior to your procedure. But less than 3 years, minimal risk, really not as much of a risk. So if they're on for less than 3 years, but they have other medical risk factors, again, those are the patients who have those comorbidities that we talked about. Certainly patients who have arthritis and corticosteroids tend to show up a little bit more often than, from what I've seen. You can consider suspending the drug for 3 months and go on a drug holiday. Would I do that on myself? No, I would work closely with the physician who's treating them. You can check this. As I said, do you have to check this? No, absolutely not. Will it give you an indication of when it's safe or not safe? No, it won't. But in our literature, as I said, that's been suggested as one of the protocols to use. Can you use that? Yes, I don't. I don't really check that. And then you can potentially after you do your procedure, you restart the drug after about 3 months of treatment. If they've been on oral bisphosphonates for greater than 3 years, again, drug holiday for a period of time. Do your treatment. You can again check this, don't check this. It's up to you depending on what you want to do. And oral bisphosphonates who need urgent surgery, which means, you know, they got an abscess, they got a major problem, you know, you need to eliminate the source of the infection because that will outweigh the risk of developing a problem. So if you need to take the tooth out, take the tooth out. If you need to do a root canal, do a root canal. You need to do something, do it. Do your job as a dentist. I mean, this is our job. We need to fix those things because leaving it can cause a bigger problem than treating it, okay? But again, do a good detailed informed consent and go over things with patients. So. Generally, the oral bisphosphonates are usually, again, less extensive, and you get more responsive to drug holidays. You want to confirm your diagnosis. You want to make sure that the patients don't have some other infection. Osteomyelitis is an infection that affects the bone marrow, has nothing to do with bisphosphonate use, or if they've been taking or if they've had radiation there, okay? Radiation changes the game. Again, those patients are more amenable to different types of treatments. We can put them in through hyperbaric oxygen. We can do different things with those patients that the bisphosphonate people just, they don't respond to. So again, it's important to make sure you've diagnosed that correctly. You want to contact your physician. And said good communication between the providers is very important. You want to discuss possibly going on a drug holiday for several months up to a year. 60% The good thing, 60% of the cases can completely go away on their own in 6 to 12 months with the drug, potentially with the drug holiday, without any kind of surgical intervention. That's good. You know, with oral bisphosphonates, IV bisphosphonates, that's a different story. You know, but with the oral medications, especially depending on time that they've been taking them, 60% of those can resolve on their own. So I don't have to do a darn thing, right? Just watch it, put them on some Paradex if they need something for some localized infection, then I can put them on some antibiotics for a period of time. You watch it, keep the area clean as best you can, and then a lot of times they'll go away. Is that 100%? No, that's 60%, right? 40% will require minor surgery. So most of the time, these guys don't need resections. I don't need to go in there and lop off half their jaw in order to take care of these things. Most of the time, minor surgeries will be helpful with those. So that's good. Minor, you know, the surgery, those types of surgeries, again, and it's hard to know, and we'll talk about this in a second, it's hard to know where do you take the bone off to. When you talk about a minor surgery, well, if you go in there and they have dead bone and you can kind of feel where the margins is and you pull out the dead bone, did I get it all? Probably not. You probably didn't get it all. You just got the little sequestrum piece that came out. Oftentimes with these, what we'll do is we'll make an incision around the gum tissue, expose that area right there, and I'll get to where that's at. And then how far do I go? You know, that's the hard thing, is do I go all the way down till I see what looks like good bone, you know, color-wise? So that's what we've been using before. We've used color and we use bleeding bone. We look at the bleeding bone and we say, okay, well, we'll drill and take away this dead stuff until we get to the bleeding bone. Well, bleeding bone really also isn't very strong. It doesn't have a very strong correlative value. We've actually been doing other things. We've been actually kind of using doxycycline and using fluorescent lamps. And if you look at that, and I'll show you, if you look at that, you'll see, you know, when you took away all the dead bone, all the bone that you saw color-wise, and now you're in bleeding bone, there's still 3 or 4 millimeters or more of dead bone still there. So we're trying to find ways that we can use to kind of give us an idea how much bone to take away. Okay? But 40% of the cases will need some sort of surgery. Nowadays, as I said, over the course of the last 3 or 4 years, I've seen a lot more literature that shows we are more aggressive with surgical interventions on patients on oral bisphosphonates in how we treat those. We're more aggressive with surgery in order to kind of take away that dead bone. And I think we're getting pretty good results from that. So, you know, right now, most our suggestions from our community really are, all right, leave that area alone, put some Paradex on it. Some of those will resolve on their own. Talk about a drug holiday. I mean, that's really, those are the things that we can hang our hat on that doesn't cause further harm. Okay? As again, the surgery community, we're not ones to kind of just sit around, and I don't like to just look at dead bone. I hate that. I look at that, I'm getting rid of that stuff. You know, I mean, that's the first thing in my mind. I want to get rid of that so I can make things nice and healthy. But you have to be careful with that, you know, especially with these patients. Dental restorations are okay. You know, as I said, don't not treat these patients. It's very important. Dental restorations are okay. Dental implants is one of those things, do you do it, don't do it. You know, you have to look at the patient. You really have to look and see what you have. If you have, again, the case, you have an 80-year-old patient who's a smoker, has got, you know, osteoarthritis, they're taking corticosteroids, they're taking these things, would I necessarily do an implant on that patient? Oh, gosh, no. I'm running like the wind. I'm saying, no, you know, look, there are other options for you. Let's do those. You know, if you've had a patient who's been taking oral bisphosphonates for a few years, they're not having any problems. Is an implant, can you do implants on them? Yes, there's certainly plenty of literature out there in the periodontal literature and the oral surgery literature that show that yes, we can do implants on them and they do just fine. Does every one of them do just fine? No. There are some patients who will develop problems with dental implant placement. They do. They develop problems. Can I give you a number? You know, can I say, well, if their CTX is this, then it'll work, and if it won't work? Can I say, if they've been on this for 6 years? No, I don't know. I mean, most of it is going to be how you interact with the patient, what your understanding is of the patient, and how much the patient wants to risk doing that. Some patients will say, you know what, I think this is a really important thing. If there are other treatment options other than implants, would I necessarily, you know, if you can do a bridge there and it's going to work fine, would I probably edge toward the bridge? I probably would. I really would. Just because I've seen when they go bad. You know, I've seen the other end. Do you necessarily 100% take implants off the table if you have, you know, if you have someone who's been taking these medicines? No, you don't have to take them off the table, but you have to be really clear in how you discuss these things. So, you know, as I said, I don't have a hard and fast rule. I don't. I kind of get a feel for the patient. I get a feel for what their interaction is with their physicians, how long they've been taking the medicine, if they have any other problems, and have I placed implants on patients who have taken bisphosphonates, oral bisphosphonates? You betcha I have. I placed implants on a patient who took IV bisphosphonates, and they did just fine. Would I recommend that? No, I would not. I would not recommend you do that on the IV patients. That was a whole different story, and they had it for other reasons. So, but as I said, these are tough questions that we haven't really ferreted out the exact answer to. You know, I can't tell you 100% of the time this is going to work, 100% of the time this is going to fail. I don't know. You kind of have to get a feel for the patient and what's going on. If I have a pretty healthy patient, they're a young patient, they're taking this medicine and they've only been taking it for 4 or 5 years, there's no other signs of anything, they have immaculate oral hygiene, do I put an implant in? You betcha. How many patients are taking Fosamax? 17 million patients. There's a lot of patients. You're going to turn away all those patients and not treat them? No. I mean, I wouldn't in my practice, you know. Just because you hear the word bisphosphonate doesn't mean it's bad. And the drug's not bad. The drug's there for a good reason. But you have to kind of weigh whether you're going to place implants on them or do certain procedures. And that's kind of what I do on a daily basis. You kind of just, well, do I do this? Do I not do this? Some patients I would be less aggressive with than others. So here's one that just resolved on its own, right? You had this thing, it was sitting right in here, same place, they always show up. They went on a drug holiday for a period of time, they put them on some Paradex, no pain, no problems, and boop, went away. Great, that's what you want. Said no treatment was done whatsoever aside from just watching it. So, very successful. This one right here, as I said, you had a little bit of exposed bone. It looks like maybe a stage, it's probably stage 1 because there was no pain, no infection going on with that area. I mean, pretty significant sequestrum, right? I mean that looks like it's all dead bone right here. Did we do anything? I didn't do this case, but basically this was kind of dead bone, and they just pulled it out. They didn't make any incisions. They didn't do anything else. That closed up, and then I don't know if I put the picture in, but once they took this out, it healed up just fine. It closed over and did okay. You know, as I said, would I be more aggressive than this? Oh yeah, I would be. Certainly, I would have been more aggressive. But that healed just fine without anything else, right? This one, a little worse, right? I mean, this is a big case, right? Some guy comes in, this doesn't look infected, but at one point it got infected. This is all dead. You look at this, I mean, this is all bad bone right here from all that's down. I mean, you look at this is all just yucky dead bone. So, you know, actinomycosis right there, you know, you got a big resection, everything kind of went in. They took out the whole big thing right here, put a big plate on there. You know, that's an oral bisphosphonate. That's not an IV. Can that happen? Yes. Does it usually happen? No. Rarely do you see an oral bisphosphonate turn into that. Can it? Yes, it can. So, I mean, here's other pictures of patients we've seen, you know, right? I mean, this guy got a big resection right here. All this is dead bone right here. This is maxilla. Oh, that's so hard to fix. It really is. I mean, you're doing a hemimaxillectomy on some of these guys because you're just taking away bone until, you know, you come into something that looks like bleeding bone. And, you know, does it usually heal over time? Yeah, it can, but difficult patients, difficult things to treat. So, as I said, we tend to see the more severe parts. So, as I said, surgeons aren't ones to sit around. We like to try different things, and so, you know, we've tried different things with using lasers. This was the ER YAG laser, but there's other lasers that are a little bit more, they go further. This one's really shallow as far as where it goes. We've used this laser as well, and that's been very successful as well. So this was published in, 2010. They had 55 sites to work on. They divided those out. Okay, we'll just do medical treatment on this one. We'll do this on this. We'll do this. So it turned out that in the way they divided out, 12 of these patients had surgical therapy with the laser in association with low-level laser therapy. They just, you know, took this thing in there and burned that out. It does a good job. This laser is good for it's absorbed well by the hydroxyapatite, which is in the bone, and water as well. So this laser actually gets pretty well absorbed by that area, and they had a good result. They had 87% had complete mucosal healing after 13 months. So that's pretty good, you know, 87%. Was it 100%? No, but this is not necessarily what we say to do things. You don't say, hey, you know, leave that alone and just watch it. Surgeons don't like to sit and watch. You know, we're not the overly patient people, so I don't want to sit and watch. I want something else that I can do to make things better. And so this was one of the things that they had done, and they had a decent result. Do they need more numbers on this to make sure to have it become like a regular protocol? Sure, but it works. You know, in this case, this was the URYAG laser treatment was more successful when they compared it with the other ones of just doing solely medical therapy, which means like putting them on a drug holiday, or doing just one of those things where you just pull out the bone but don't really take out any of the dead bone around it. So that's one thing people are doing. This one was got a little bit of attention. This was the one where we actually we gave patients 10 days of doxycycline pre-op, and then we used a fluorescent lamp in there. And then when you use a fluorescent lamp on bone, it actually shows up like really nice and green and bright, which is nice. So basically, they had them take the doxycycline. They did the surgery, right? They opened this whole area up, and this stuff is the live bone. That's the good stuff, right? When you look here after the debridement, that's what's still there. I mean, that's all that, and that's the only stuff that lit up. So you needed to go a little deeper, didn't you? You needed to get down to the good stuff, right? This is where they went, just to bleeding bone. So we can't always just go to bleeding bone. If you go to bleeding bone, is that still healthy? No, that's not necessarily healthy stuff. We need to go a little bit deeper. So we found that we're a little bit more aggressive, or these guys were a little bit more aggressive in the way they did that. So they took that out, they looked at the bone, then what they did was they took away more bone, and now, hey, this is good stuff. I mean, that's the stuff we want to have. So they used a fluorescence-guided lamp. They used a fluorescent lamp to help them decide how much bone to take away, and they had, again, good results. 85% of the patients who showed up with mucosal lesions, and again, these were stage 2 and stage 3 lesions. None of these were stage 1. These were more aggressive, and they had already failed conservative therapy. So they went through conservative therapy, didn't do a darn thing. They were still having problems. Okay, well, let's be a little bit more aggressive, and they had something to use. And again, that's all we're trying to use with the CTX or with the fluorescence or with anything that we're trying to get information on. We're trying to get data so we can make a good decision at the other end. And do we always have an easy answer for these patients? No, we don't, but we're trying. We're really trying to work through things to get more information so we can make good decisions with these patients. So I like this. I haven't done this yet, but I really did like this paper. I was really excited about it. I'm really kind of hoping to see more information come out on that. This was just a pilot study that they did, so I think over time we'll see some more information on that. And I'd like to see at least something that I can use to really help me decide where to do surgery. And again, we can be more aggressive in the beginning before they turn into that big resection. I hate to, as much as the resections are fun, surgically as a technician, I enjoy doing those things. It's just, for patients, they can be devastating. They can be very, very, very difficult to get better.